Like most GPs, I feel very frustrated by not being able to move as quickly as we'd like to deliver better services for patients. And it's very often difficult to focus on what the solutions are.
The way we provided general practice services for years has remained largely unchanged. That often is not a particularly efficient way to work. And I think the other thing that's important is that the default is still doctor. Certainly in our practice, the patients come in to see the doctor.
I think traditionally in general practice there isn't a great management system. We all have our own roles and by and large we're left to get on with them.
And it's not uncommon for a patient to come and see a clinician, to then have a blood test ordered, to have to go out, wait at reception desk, make another appointment for a blood test, wait for that blood test, have the blood test, wait for the result.
My biggest frustration is running out of appointments, and you can't ever time manage the book because every day is different.
A patient phones up who's upset, you know that they're obviously feeling quite low and there isn't an appointment to give them, and we're trying to help, but they don't see us as trying to help, they see us as trying to block.
Of course, one way of dealing with extra demand for extra work is to just employ extra people, but in a resource-limited organisation like primary care or GP surgery, we just don't have the resources anymore to do that.
We are where we are because we've evolved into our current position. In stepping back and looking at the problem globally, you can make fundamental change to the way the practice operates to deliver those services.
So how do you go about making fundamental change in something as complex as general practice? It all hinges around how we use our capacity. Capacity is the time we have available to provide care for patients, doctor capacity, nurse practitioner capacity, and so on. And the effectiveness of any organisation is determined by how precisely it can manage that capacity to meet demand. If the demand is predictable, then planning your capacity to match can be easier. If it's unpredictable, as in general practice, then it's more challenging. Of course, the main focus of demand on the practice is the appointment system. This is a model that's endured through years of change. Patients phone in for an appointment and we allocate some of our capacity to them. But this fundamental approach of allocating capacity in reaction to a patient's request limits the extent to which we can allocate practice resources to best serve the patients. It doesn't allow for the different levels of clinicians who might be able to meet patients' needs. Also, appointments are often taken by those who shout loudest. Many have to wait to get an appointment, and some can't attend appointments during normal practice hours. If people can't see a doctor and diagnosis is deferred, their health outcomes may be affected. Some might go to A&E, which is not the appropriate place for their care needs to be met. Another drain on capacity is in the non-patient facing work that clinicians have to do, what could be referred to as managerial, and which frequently extends outside normal working hours. A workload that will increase with the commissioning reforms. So increased demand, more managerial work, means more capacity will be required in the future. But where's it going to come from? More staff means more money, so that's not necessarily a solution. And of course, knowing you need to change is one thing, but finding time to do it is another, with the day-to-day pressures of meeting patient demand. While we're used to measuring many things in general practice, measuring demand for our services isn't something we usually look at, so most of us don't really understand how our capacity is being used. That's where shaping our future practice comes in. It provides a structured approach to rethinking services. It helps you find ways to measure the demand on your services and make it much easier to match it to your capacity. And it looks at fundamental change to the way practice capacity is allocated to patients, moving away from the traditional reactive appointment system to something that is more proactive.
Shaping our future practice is a step back from the position we've evolved into. We have become increasingly constricted by treating diseases in their individual silos, and this has in some part been driven by QoF, and it forces their carers into delivering care in those particular packages of care, which may not actually meet the needs of the patient.
Appointments, how can I help you?
Shaping Our Future practice really enabled us to take a look at all our patients and actually see if we could actually put those patients into certain groups that were predictable, and just to see if we could design certain pathways for certain types of patients, which would mean that we could actually help to manage them in a different way.
So what could a more proactive service model look like? Well, first, the practice services will have been specifically designed to meet the demands of patients. The practice has gone through a deliberate and structured process of understanding the demand on its services and then organised themselves to meet that demand. They've also taken the proactive step of understanding what their capacity is required for, rather than waiting for patients to request it and then reacting to that by allocating capacity through the appointment system. Because many of patients' healthcare needs are known to their clinicians, the design of services can be based on clinical need. A patient diagnosed with one or more long-term conditions has a specified plan of care over a period of time, and the resources required to provide that can be determined. This makes the capacity required predictable. It's the fact that the capacity requirements are predictable that makes it possible to be proactive rather than reactive. The Shaping Our Future practice concept is to group patients with similar patterns of care and that use resources in a similar way. So a curve like this represents a typical situation, a high average number of attendances and a wide variation in how often people attend. What we're looking for is a curve like this, fewer average numbers of attendances and a narrower curve representing a reduction in variation. This is achieved by increasingly shifting unpredictable care to predictable care. Clearly, there will always be an element of unpredictability, flu, coughs, muscular problems, for example. So, this also needs to be allowed for. But whilst we can never know what condition each patient will present with, we can estimate the overall volume of request and the type of clinical expertise that will be needed. Over time, this unpredictable demand can be identified as having characteristics of a more predictable condition. So the practice can gradually evolve to a service model where the area of unpredictable demand is reduced. Of course, we also need to include in our planning other streams of work that would absorb clinician capacity, training work for example. Or a practice might want to target patients who are not presenting themselves for care, introducing a preemptive stream of work to take a preventative approach to healthcare. And the managerial workload needs to be allowed for, to avoid this falling outside the normal capacity of the working day. All in all, a challenging process, but Productive General Practice will lead you step by step through a series of 6 workshops to help you turn the concept into reality.
To be effective in offering services to patients, it's often better, and we learn from looking at our data that it's better, to deliver things in a more generic way for their condition. So, for instance, macular degeneration, dementia, chronic kidney disease, heart disease, they all have the common thread of being vascular diseases, diseases where the blood vessels have silted up and cause problems in the end organ. And you can group those conditions together and offer skills through particular people within your practice to meet those patients' needs in a common way.
So we were cutting down on telephone calls to the practice, more letters going out. So we're actually managing the patient as a whole rather than in a disjointed way.